Hello, good afternoon to all the colleagues in TransplantChild. It's the first webinar for our working group in healthcare, and it's about the results of the first clinical audit we have performed on PTLD. Okay, my name is Esteban Frauca. I'm a member of the Pediatric Hepatology and Liver Transplant Unit of the Children's Hospital here in La Paz, in Madrid, since 1982. And I'm also a member of TransplantChild Executive Committee and a member of TransplantChild Healthcare Working Group as a coordinator. The Executive Director of our working group is Dr. Alastair Baker. Okay. Well, all you know that PTLD, post-transplant lymphoproliferative disease, represents a major concern in the long-term care of pediatric transplantation. PTLD has been demonstrated as an independent risk factor for graft and patient survival. You know that transplanted children represent a population at risk for this disease, since a high percentage of them are seronegative at transplant, between 50 and 70%, and become infected afterwards. The incidence and mortality of PTLD has decreased significantly through the adoption of different measures related to its prevention and treatment, but this approach still represents an important workload in the follow-up of these patients for all of us. And at the moment, there is no standard approach generally accepted in many aspects related with the prevention, diagnosis, and treatment in PTLD. So with this background, the Healthcare Working Group decided that the PTLD could be included in the project of clinical audits on topics in pediatric transplantation in which there is no absolute consensus between the different programs. So a questionnaire was agreed and elaborated by the working group and was sent to all centers to be filled out by each of the transplant programs. It included the report of PTLD cases, new cases diagnosed between 2012 and 2016. And at this moment, is pending a definitive analysis of the results. So these results I'm going to present to you can be seen as preliminary data of this PTLD audit. Well, we have received responses from 36 different transplant programs, including 9 hematopoietic stem cell transplantation programs and 27 solid organ transplantation programs, including 10 liver, 8 kidney, 3 heart, 3 intestinal, 2 lung transplantation programs, and 1 combined liver and kidney program. Starting with the cases, the new cases reported and diagnosed in between 2012 and 2016. This is the distribution by centers. Logically, the centers that I reported more cases are the ones who have more active programs in pediatric transplantation. This is the numbers. We have recruited 161 new PTLD cases from diagnosis from 2012 and 2016, with a gross survival rate, really, I think, satisfactory of 72.6% of the cases. As you can see, the highest number of cases are from liver transplantation, probably because liver transplantation programs are more represented in TransplantChild than other type of organ programs. Well, this is the primary tumor sites. As you can see, the highest number are located in the gastrointestinal tract, in the second position, these other abdominal locations, and the third place, this ear, nose, and tonsils area with 15 new cases diagnosis. But are cases for another location, is the transplanted organ, the graft, or retroperitoneal or mediastinum, etc. Well, starting with responses to the PTLD questionnaire, it included 28 items. Those items were related with a different situation in this natural process of development of PTLD. Some of them related to the post-transplant prophylaxis of PTLD, of EBV infection. The next phase, the approach to treat patients as a preemptive treatment, those patients that become infected by EBV, diagnosed by a positive PCR, and in those cases that develop at the end a PTLD, the diagnostic and treatment approaches, different treatment approaches. Regarding the PTLD prophylaxis, as you can see, most centers, 93%, don't consider an EBV match or mismatch in donation, and only 2 programs consider this match or mismatch. Regarding the CMV antiviral prophylaxis, 75% of the programs perform some kind of prophylaxis. The rest, 35% of centers don't do any prophylaxis against CMV. You know that CMV is one of the risk factors that has been considered in the development of PTLD. Well, it's very different, very variable. For how long centers perform prophylaxis, between 2 weeks and 12 months. Only 42% of the cases of these centers, of these programs, perform universal prophylaxis, and the rest, 58% of programs, only do prophylaxis in what they consider as risk cases for CMV. But otherwise, all centers treat CMV with antivirals once they demonstrate positive viremia. Regarding the EBV infection surveillance, most centers do viral load monitoring, PCR, 30 out of 31 centers, and only 1 center perform this kind of EBV monitoring only in those cases at risk, as they consider EBV PCR negative cases as transplant. Regarding the sample, 16 out of 24 cases programs performed PCR in blood, 6 out of 24 in plasma, and 2 in both blood and plasma. Regarding the PTLD preemptive treatment, this is the treatment approach in those cases once we have detected a positive viremia, EBV viremia. 58% of the cases don't manage a cutoff value of EBV viremia for starting the treatment, this preemptive treatment, and 58% have starting the treatment, depends on a cutoff value, and in contrast, 42% of the centers of the programs don't manage a cutoff value. They start treatment only once the viremia, the PCR, become positive. 50% of the programs use other parameters of risk to guide the preemptive treatment. Most of them, centers perform a monitoring of the population of cytotoxic T cells, EBV-specific T cells, cytotoxic against EBV, and the other half, 50% of centers, don't perform any other parameters or don't use any other parameters to guide this preemptive treatment. Talking about the different possibilities of treatment, the different preventive treatment modalities, all centers 100% reduce immunosuppression once they have detected positive viremia for EBV. Regarding the criteria for reassuming these immunosuppression previous levels, 14 out of 20 programs, this criteria is the decrease in EBV viral load, and other 6 programs prefer the wait-and-see approach, just to, only in the case that the patient shows some signs of rejections, restart or reassume the immunosuppression previous level of EBV. Well, other modalities of treatment, preventive treatment, most centers, 77%, don't use antivirals in those patients that are EBV positive. Only 7 programs, that represents 23% of the programs, use antivirals in this setting. Regarding the PTLD treatment, most centers, practically all centers, decrease. Most of them stop immunosuppressions at the moment a PTLD is diagnosed. It's no common approach the surgical removal of the lesions, so only 37% of programs refer that they practice this surgical remove against 63% of other programs that don't. Regarding chemotherapy, most centers, 92%, use chemotherapy in the treatment of PTLD in different settings with different indications. Most of them when a lymphoma is diagnosed or when the PTLD shows no response to other treatment considered as a first-line treatment. Regarding other possibilities of treatment, rituximab, all centers, all responses refer to use rituximab, but in different settings, in different scenarios, as PTLD type 2 or 3 in the WHO classification. Regarding the use of cytotoxics, the EBV-specific cells in the treatment of PTLD, most centers don't have experience or don't use it, this type of treatment, 77% of them, and only 23%, 9 out of 33 programs refers that they use these cytotoxic T cells in treating PTLD in different indications. So, in summary, I think that we have assembled a cohort with a significant number of cases that is pending the final analysis on them, 161 cases, with a gross survival rate of 72% of them. I think we've got a valuable information, and we have to extract the more information about this data. And secondly, regarding the responses to this questionnaire, diagnostic, preventive, and therapeutic approaches in PTLD, I think that the responses reveal that we share some common attitudes in PTLD prevention. Most of us treat CMV once the infection is detected, but not is so such agreement in regarding the CMV prophylaxis after transplant. Most of us don't consider match or mismatch in EBV status in donation, and most of us practice some kind of surveillance of EBV infection. Most of us performing periodical EBV load monitoring. Regarding the EBV infection preventive treatment, in most centers, in most programs, it's guided by the EBV viremia, by EBV viral load. Most of us decrease immunosuppression at the moment this infection is detected, and most centers don't use antivirals as a treatment in this situation. Regarding the PTLD treatment, most centers decrease, most of them stop even immunosuppression. Most centers use rituximab and chemotherapy at some stage in some specific situations, but most centers don't use cytotoxic TBV specific cells or don't have experience with this kind of treatment. And we have seen huge differences in other kind of treatment options, as it could be the surgical removal of the PTLD tumor. So, if you've got any questions about this presentation, please send me to this email direction address. Anyway, these results, I will present them again in the next board to be held in Brussels the next week. And this presentation and the final results, once we will analyze all this data, we upload to the TransplantChild platform, so there will be the results. So we've got now other tags on a definitive analysis of this interesting cohort of PTLD cases, 161 cases, diagnosis between 2012 and 2015. And we've got to analyze completely the responses you have kindly sent to us in diagnostic and therapeutical approaches to PTLD. And I want to remind all of you, especially the members of the healthcare working group, that we will have to define new topics for this kind of interesting, I think, clinical audits in pediatric transplantation. So thank you very much for your attention.